Welcome to this episode of MyDiabetesHQ Live. My name is Joy Ashby Cornthwaite, and I will be your host today. I'm a certified diabetes care and education specialist and a volunteer for Cities Changing Diabetes Houston. Maintaining diabetes is very complex without the added burden of obtaining the right medications. When you add that on to find the ones that work for you, the ones that are recommended by your physician, and the ones that are also covered by your insurance plan, it can add an increased burden. For many Americans without health insurance or inadequate prescription drug coverage, patient assistance programs, or PAPs, offer important safety net solutions. Today's episode is coming up next. You don't want to miss this. Before we begin, a gentle reminder, the content that's shared during the MyDiabetesHQ Live broadcast is not intended to be a substitution for professional medical advice, diagnosis, or treatment. Always seek the counsel of your physician or other qualified health provider with any questions you may have regarding your medical conditions. This weekly broadcast is developed and produced by Cities Changing Diabetes volunteers in Houston and Philadelphia. Our two cities are the U.S. members of a global network of 36 cities working to improve diabetes care, management, and prevention all around the world. You can learn more about Cities Changing Diabetes by heading over to citieschangingdiabetes.com. The purpose of this live stream is to help people living with diabetes and their support teams. And today I'm joined by my guests, Dr. Otis Kirksey, Director of Pharmacy Services for Neighborhood Medical Center, a federally qualified health clinic in Tallahassee, Florida. Hi, Otis.
Good morning.
Good morning. I'm so happy to have a fellow CDCES serving as President-elect for Healthcare Education with the American Diabetes Association.
Thank you. Thank you. Exciting times.
Awesome. And we also are joined by Ken Inchausti, Senior Director. Good morning, Ken. How are you?
I'm well, thanks.
You are Senior Director Communications for Novo Nordisk. And I just want to take a moment to give a big shout out, a big thank you on behalf of all of the Cities Changing Diabetes teams. Thank you for being so instrumental in bringing Cities Changing Diabetes to the US and to Houston. Certainly without your leadership and that of Karen Gillespie, we wouldn't have Faith in Diabetes, peer support, all the other great programs here in Cities Changing Diabetes Houston, and most of all, this show right here, MyDiabetesHQ Live. So thank you.
Absolutely, and I am a alumni of the American Diabetes Association way back in the day. The power of volunteers, the power of patients who get together and really rally around this cause. That's what makes the world go round. That's what's driving a lot of change within the community. It's not folks just like me, and it's not simply just other organizations. So Otis, thank you very much for your leadership at ADA. Joy, thank you for hosting, and I'm really looking forward to this conversation.
Excellent. So we are going to begin with Otis. I'd like you to start off the conversation because I think it's really important to connect what we're talking about today to the work that you do in your community.
Yeah. Well, thank you, Joy. First of all, as a pharmacist, I have to reflect back and look at how drug therapy for people with diabetes has changed or evolved over the years. When I graduated from pharmacy school, we were basically limited to animal source insulins and the old sulfonylureas that had a lot of bad side effects. Patients would have hypoglycemia, they would have that suffer around reactions if they took the medication and had a drink of alcohol. And the insulin caused a lot of lipodystrophies and other allergic reactions. And now, as we in 2021, we have a plethora of drugs that are safer, more predictable, and they address multiple pathophysiological defects that occur, particularly in patients with type 2 diabetes. So the question is, why is it important that people have access to newer, safer drugs? And the answer to that is that they are more effective and more predictable, and the use of those drugs end up with more greater positive therapeutic outcomes. And so I practice at a federally qualified community health center. My patients are primarily uninsured or underinsured. We have a significant number of Medicare patients, and oftentimes during that donut hole time, they have experienced co-pays that are just out of this world. And so, our challenge is how can we access or help our patients access these newer drugs that address several different comorbidities that, in the diabetes scheme, but that are so expensive. And so we are fortunate to have access through Data Services, which is a tremendous tool that our clinic uses through our case management department to access drugs from drug companies. And so patients can have the top of the line drugs, and even if they can't afford it. And this is tremendous benefit and service that the pharmaceutical companies have provided to our patients, so that they can experience those benefits that people with insurance can experience.
Yeah, and you speak to a lot of really important considerations, Otis, because I know working in my clinic as well, it doesn't matter who the patient is who's living with diabetes. There are going to be some sort of issues related to acquiring medication for them. I mean, the loopholes that we have to jump through to get insurance coverage. And I think that patient assistance programs have greatly helped even our ability to help our patients. There's nothing worse than seeing a patient, knowing that a medication would work best for them, that's physiologically closer to what they're needing, and not being able to access that. So I'm coming over to Ken now.
Mm-hmm.
So our viewers may be wondering, right? You as a part of the communication team at one of the top insulin companies in the world, how does a drug manufacturer find themselves aligned with or joined with the efforts of clinicians like Otis, advocating for equitable care and access to medication to all people living with diabetes? And I think most importantly, why?
Sure. So I think first and foremost, we've always believed that open access to medicines is absolutely vital. And I recall even back in the day when Otis talks about the growth of medicines we saw in the 90s, what came about relative to a lot of oral medications coming on the market. And now we've seen since 2010 and up, the new insulins that have been made available, and the GLP-1s that have been made available now through companies like ours, that making sure that people have that ability to access that is incredibly important. Every day we have people negotiating with payers, the insurance companies, and talking to employers about the value of good diabetes care, diabetes management, prevention. And why does it make sense? Why is it important for us to do it? Because we do more than just develop medicines. I mean, we have a whole commitment around shared value with the communities we serve. That's why Cities Changing Diabetes was created. It was designed. That program was completely designed based on the fact that no single entity, no organization, no company can do it on its own to be able to drive change within the diabetes space. And so working in partnership with folks like you and with the ADA and community organizations becomes really, really vital for us to be able to ensure that people who need to know about the seriousness of diabetes, which we all know still doesn't get the respect it deserves, everybody needs to be screaming that from the mountaintop. And ensuring that people have access to medicine is absolutely critical, because that's going to stave, as we all know, it's going to stave off those complications. So we're in it not just in terms of being a medicines developer, but also, I mean, by advocating on behalf of patients on Capitol Hill, and also again doing all those negotiations every day to ensure that those medicines people want are on formulary. And if people can't, or if it's not on formulary, offering some alternatives for the uninsured or the underinsured to make sure that they have access to those medicines if they so need them.
Yes.
That's fantastic. And so, and I appreciate it, and I know that it's important, and I talk to my patients about using them. I think that we're here together this morning to do what I think all have done so well in our careers, and that we continue to do. I think this is an opportunity for us to extend our network even further, right? Mm-hmm. So the things that the knowledge that you have, the development that you've done at Novo Cares, and also the work that Dr. Kirksey does every single day, the work that I do, we're kind of siloed, and I think I want to discuss how we can put that together and tackle this challenge of medication access. Sure. So let's start with, what are patient assistance programs?
Is that for
Ken or?
Sure.
Yeah,
so I mean,
either of you.
Yeah, so from our perspective, there's patient assistance programs, which basically are programs that offer free drug to people who are eligible. So there are a variety of criteria that are required for that. But then I think there's one layer above that, which is patient support programs, which you see in the form of cash card programs, copay card assistance. And so, for us, we sort of, it sounds like semantics, but, semantics are important in our business. And so we do, we sort of make sure that we're creating a holistic program, or holistic programming. And, our legacy programs, used to be copay cards, patient assistance programming, and a partnership we had with Walmart that started in around 2003, in which Walmart would provide Novo Nordisk human insulin for $25 a vial. And, things changed a great deal, in which we saw how insurance programs, benefit design was changing for a lot of folks. So what we see is a rise in the high deductible health plans, which, when you think about that, someone who's looking for insulin, all of a sudden they're having exposure to the list price of insulin during those first few months, when they're having to claw through their way through a deductible. And of course, the issue of trying to make sure that people who are at risk of rationing, or at risk of the threat of rationing, they need help right away. So, we had several discussions with people out in the community, friends and critics alike. Our CEO, global CEO, went and did a bit of a listening tour with a number of organizations and individuals, and even friends of mine in the press, to talk about this thing. And then in early 2020, we launched 3 new programs designed to help improve the ability for someone who needs insulin for them to be able to access it. Because, like we said, there's no one solution that's going to solve affordability. Everybody comes to affordability in one form or fashion. So first of all, from the legacy perspective, the $25 human insulin that we provided through Walmart, you can now get that through CVS and other national pharmacies. Then in 2020, we launched what we call an unbranded biologic, which is a authorized generic version of Novolog and Novolog Mix. That's at half the list price. So if you're in a high deductible health plan, that will help you do that. We have a program called My $99 Insulin, which basically, for a $99 cash card, you can get 3 vials or 2 packs of pens of insulin that you need, and you can mix and match. And that, for the most part, we know from prescription data that covers a month's worth of insulin. And then we have for people who say that they're in need, we have an immediate supply program, which basically, if you call or you indicate that you're at risk, we have the ability to help you right away while you get situated to move things along and find other solutions. So, we took that to heart. We took to heart that things had changed quite a bit. And so we worked really diligently to create programs that would sort of modernize, if you will, our programs. And a lot of the other companies have done the same.
Yeah. And Otis, how can you, thinking of all of these, this difference in programming, differences of approaching this need, how do you think these address and support healthcare equity, especially for people in your community, and have you used any of them?
For sure. Well, it definitely helps to level the playing ground. And the question is sustainability. And, always my concern is once you start a patient on something that works real well, how long are they going to have access to that? So that's always a concern. Our patients are somewhat unique, and many of them don't have $100 copay for insulin would be too much for many of my patients. $100 will cover their water bill and part of their grocery bill for the month. So we oftentimes, particularly when we onboarding a patient in terms of new therapies, we depend on samples, we depend on coupon cards. One thing about it is that, and I've been practicing pharmacy for a long time, the pharmaceutical sales force, there's been a change in philosophy, and I'm just going to say it in terms of they are almost like part of the team. And it's always about how can we help you help your patients. And before it was all about money, making that money, making that sale. But, very simply come in and ask, well, how much you guys are writing for this or whatever. But it's more about that, the Kirksey. How can I help you help your patients? You need more coupons. So there's some that provide you the first 2 weeks supply. In order, and that for our uninsured patients, that'll give them a little lift until we can get patient assistance to kick in or whatever. Some of them will provide a month supply coupons. So we depend on, it's almost like being a magic man, putting a little bit of this, a little bit of that. We depend on the 3-month supply that the companies will provide through the patient assistance programs. I mean, that is a lifesaver. And, since COVID came on, being able to deliver those directly to the patient's door, it's tremendous. But there's also a second side of that, in that we found that a lot of patients, you order those meds and those patients won't come and pick them up. So there is a case management piece there in terms of when they get the 3-month supply and they get that for a whole year, there's an effort to really keep them engaged in primary care, because you can end up losing patients in terms of because they have a drug supply and so they're not monitored. So there's a loose end sword there, but I'll take that any day over not being able to provide access to the level that we're doing right now, thanks to patient assistance programs.
I think Otis is actually touching on something that's really important, and that is, it's not just simply about whether or not a patient assistance program is going to provide that supply. It's also continuity of care.
Yes.
So, as an example, and one thing I neglected to talk about because I'm seeing COVID coming up in the chat. So, in April of 2020, we announced we had enhanced extended our patient assistance program for people who would indicate that they had lost their insurance or diminished their insurance had diminished because of job loss or job change due to the pandemic. 3-month supply, no questions asked. But what we also considered, and what we also were really in our press release, we were really we wanted to make sure people understood. If your insurance has changed, consider trying to get into Medicaid, trying other sources, because it's simply not enough just to get that medicine from our patient assistance program, because that doesn't connect directly to that. It just one's. So, our hope was that if people were able to get back into care in some form or fashion, Medicaid seemed to be, from our perspective, the likely solution. Then also that would also take care of the medicine component, because our insulins are found, I believe, on every Medicaid program, or most Medicaid programs in the United States. So we were really concerned about not just about people getting that medicine, but it was also about, are they going to get that continued care that's going to be needed through all of this?
Yeah, that's a very good point, Ken. And I had a patient the other day who's at Medicare age, and is not on Medicare Part D. And that patient's life could be a whole lot easier, and if they access Medicare. And so I was able to afford that patient to case management. They jumped right in to help get that onboard that patient into some Medicare program. And a lot of it's just education. People don't know. Particularly my patients, they sometimes they're always suspicious, in terms of they don't know the difference between Medicaid and Medicare. And in Florida, is very difficult for anyone who is not a woman of childbearing age to get on Medicaid. So there is a huge population of people out there are just not covered. So once they get to the age where they can benefit from Medicare, we're going to try to get as many of them in on that, so that we can ensure that they can experience the kind of continuity that we know results in positive outcomes.
Just a correction here. I'm seeing in the comments here about a comment I made here about critical to get patients enrolled in Medicaid. Yes. Medicare Part B is actually for different drugs. Part B as in boy, does not cover insulins. Medicare Part D, as in David, does. So I just want to make sure that it's well understood there. We're talking about Medicare Part D. And you're going to be in Medicare Part D if you're a senior citizen anyway, or if you've qualified to get into Medicare early. So, it's just basically going to be really a factor of where you're at within enrollment at that particular time.
So I have a couple of questions that came in, and I want to see if you all can tackle them, because this is a really great conversation. Someone asks, Umesh asks, what are the measures to determine if one is adequately or insured or underinsured when it comes to their pharmacy benefits? What questions I think would an individual need to ask themselves, I think is really.
I don't know if it's about questions that they need to ask themselves. In all of this, everybody's involved, especially the person with diabetes. And it becomes really it's really critical, I should say, that they really get to understand their health insurance, the benefit design that they've got. And I know that sounds like, Ken, are you putting it off on the individual? No, I as an individual, I look every time we have to re-up, open season, November, or for Medicare, you're advocating, we communicate to constituency on social media. It's open enrollment, time for you to actually read benefits that have happened, because we've seen in too many instances how people sort of misread benefit design. So that at the outset, for example, of ACA, people went for the bronze plans and thinking, oh, the insurance is really cheap. But what they didn't realize is down the road, the benefits were different than, I won't say not as robust, but they were different than what you saw in the higher plans. It's the same thing. You're going to go into a PPO or high deductible health plan, you have to understand what you're walking into. I also think that the other component is that if you're requiring patient assistance, we do, our phone center does actually have conversations with individuals about what their benefits entail, and also understanding where they're at in terms of income and things of that sort. So, but it really, the literacy around insurance, I'm just saying it in a little bit of this is my own take on it too. I wish that there was better transparency.
Yes.
For people, for people to understand, because I look. My parents are here outside my door here, and I think, and we have a conversation every year about Medicare and what they're going to and re-upping and making sure that what their benefits are going to be. That's a conversation everybody has to have, and it's there. It's not easy. I wish it was easy as shopping on Amazon, actually.
Well, for those patients who don't have a healthcare advocate or someone to really explain things,
Yeah.
The direct to consumer advertisement, a lot of these plans, they reach out to the patients, and patients sign up and they don't know what they're signing up for. They don't understand what the formularies are and what, they're going to have access to this and access to that. And so that case management plays a very important role there, because particularly if you have someone who's working on behalf of the patient, can sit down and go through those things. It helps a lot, as opposed to someone trying to negotiate that terrain by themselves. I mean, I would consider myself highly educated, but I still have problems sometimes trying to understand exactly when I have the best policy for my family and myself. So I can imagine how intimidating that whole process is for people who are not as literate as it comes to as needed to really process that information.
Yeah, and we go, in my work every day, I go through it with patients to say, we sit down and we say, this is what your doctor wants to order. And we go through the whole rigmarole of which is covered. It leads us to one of the questions that Umesh also asked, which was, changing. How concerned can someone be with changing their medications from one med to another med because of coverage changes and things like that? And I think that understanding and knowing what your plan benefits are, and even asking the question perhaps ahead of time, like, how do I choose a plan based on the plan benefits that I prefer, that will work for me, is something that I think that we need to work on.
That's a bigger, to me, that's a really big conversation. You can have a whole other show about that. But I think it's also, if your employer offer, the HR department, you have an HR department, and they have the ability to sort of walk you through. That's the one thing. Again, wishing that there's some transparency there. I know that there are resources that insurance plans can offer to help people walk through all of that. I would say that so I can't be really expert about what happens when formularies switch or the preferred drug lists switch, but I do know that I have heard anecdotally that it is a bit of a challenge, and I have seen calls or gotten calls myself, because my phone number is out there, about people who do struggle to when you got one insulin on formulary 1 year, and all of a sudden that gets kicked off, and we do try to figure out ways of staying on formulary. And quite frankly, we wish there was a bit more consistency about that. That's become, again, the fact of limited resources within the healthcare system, be able to cover everybody. And I believe there's some mechanisms in which you can try to get exemptions as necessary. But then again, as Joy, as you're talking about, get ready and hang on for about another week, to walk through that entire process.
I tell my patients, literally, some of them will probably tell you, Joy says, get our vests and our suits ready. We're about to go in for a battle, to decide if we can get a prior authorization or an override through letters of medical necessity, all of those things. But again, if your clinician isn't aware, or if you yourself aren't aware that those are valuable options for you, then it becomes sort of, it's hard to get into that program. Before we go on to our next question about partnerships and how important, because I think we've laid the work to understand that there are so many ways to get to the same endpoint in terms of acquiring medications or gaining access to medications. I think we do need to, just for a second, answer a question from one of our viewers, but I think we can come back to how important partnerships are in accomplishing and connecting all of the things that we just spoke about. So one of our core initiatives team asks, what about individuals who make too much money to qualify for Medicaid, but don't make enough to pay for medication? Patient assistance programs can only do so much, and they're saying they're asking for a friend.
I saw that. I was like, all right, let's.
Well,
we're happy to help the friend.
Yeah.
Well, actually, that's what this is all about. I mean, people who work every day, and I mentioned that group of people in the state of Florida who, you know, they work every day, but based on the laws of Medicaid in Florida, they cannot access that type of help. And so if they work every day and they don't have insurance, they can't apply for Medicaid, you know, they need to seek out a federally qualified community health center, because those centers are strategically placed in most counties throughout the country, and they have access to the 340B prescription program, which was originated out of the 1990 Medicaid discount rebate act. And so these through the 340B program, you can access many, not just diabetes medications, but all of your medications at a significantly reduced price. And so you're not out there by yourself. There are some alternatives for you, and you can still access some of the patient assistance programs in addition to the 340B program. We use both of them actively. 340B as in addition to patient assistance.
Yeah, I like how you were talking about that, Otis, because there are, you know, even for patients who have insurance plans, but maybe don't have adequate pharmacy benefits through that insurance plan. For example, I've seen many patients, especially during these times of COVID, who have come in and we've ordered, and you know, this is the beginning of the year, so we've ordered medications for them that they have always been taking, and they are employed. They do have insurance, but they have high deductible plans or very high co-pays or co-insurances that they're not going to meet this early into the year. And I can tell you that I have used Novo cares, and I have used a combination of copay cards, and we've used all of these. You have to use all of the things at your, you know, that are available to you to get costs down for patients so that they can maintain and continue their care. It's really important. And I work with mommies and pregnant mommies. And so it's even, you know, for us, we have 2 patients involved, and then their family members and everyone who's afraid for their, you know, for their care. And so I think that we should pivot over to how having the community partnerships, right? Having the pharmacists say, these are available things for you. Having patient assistance or patient support programs at the ready in your Rolodex. Look, I'm aging myself. Maybe in your contacts list. Let's talk about how we combine those things.
I'll send you my business card later. So actually, before we go, I see a question here. So Otis, you might want to define federally qualified health centers.
FQHCs provide primary care, and anyone, even those people who are insured, can go to FQHCs. We have patients who have commercial insurance, we have patients who have Medicare, we have patients who have Medicaid, and we have uninsured patients. And the beautiful thing about the 340B program is about the commercial insured patients help us to take care of the uninsured patients. So it's kind of a complex thing, but yeah, you should be able to get full primary care. And anyone is eligible to go to a FQHC, not just uninsured patients.
Mm-hmm. And the nice thing about FQHCs or federally qualified health clinics is that they are in the community. So the really amazing thing about them is that oftentimes you will find community health workers, you will find case managers who live in the neighborhoods know about the programs, know about resources that are within walkable distance or very close to the people who need it most.
Yes. Yeah.
And so I think that's an additional, it's kind of like a village, a health village and a health ministry,
Right.
all in one.
Yeah, they have a significant outreach program like at our center. I mean, they go out to the homeless camps and they take the mobile unit out there. They can actually provide limited care out there, but they can sign patients up, for care. That mobile unit is one of our quote registered practice sites. So, we have patients who are homeless that are part of our, patient group of patients that we serve. So you're right; they are in the community. People feel comfortable with them, and they have a vested interest in making the overall community healthier. So,
yeah.
So
let's
go back to your question.
Yeah, let's talk partnerships.
Yeah.
Go ahead,
so
Ken. I think you want to talk about a partnership that you have right now.
Yes, and I think it is, and I think it is kind of related to what your question of who's asking for a friend. So one of the things that again, the fact is that we've got to figure out and offer up a variety of options for people, because, like I said, people come to this very differently, and Beyond Type 1, which is an online diabetes advocacy group, we've partnered with them. We sponsor a website, along with the other manufacturers. They do it as well. We sponsor a website called getinsulin.org, and it's an interesting tool because they have done research to talk about those moms that you referenced, Joy, where mom who's working multiple jobs, trying to raise kids, really looking at what happens when someone in her situation and someone in a busy situation goes through one option and then assumes if they get rejected for that option. And I think the question here is what happens to that person who makes too much to qualify for Medicaid, but still is sort of in that gray zone. And we see that gray zone. Someone doesn't know where to go. And what the getinsulin.org site does, you input some information, you go to that site and you provide some information. They will provide, it actually will generate what they call an action plan, which would, if you're using a Novo Nordisk insulin, our programs would show up on that action plan, but other options are going to show up on that action plan too. Options that we might not be able to, we can't provide because we don't, we don't manage those programs. And I think that gets to another issue that's coming up here, much in the same way as the question of FQHCs and what are those? It's the awareness piece. I think we've had a bit of a discussion about sustainability of programs, what's offered, how what's available to people, but also I think it's really vital that people are aware of these programs too. I think that's half the trick. Well, half of it is having those programs available, and then the other half is making sure there's proper awareness. So, for example, during the pandemic, between April and we did for about 2 months a campaign around NovoCare that was very targeted, online, digital. It came into certain TV platforms, et cetera, and really making awareness about NovoCare available for people, because at that time, people, again, we saw people rushing to get 90-day scripts filled, but there was a whole host of other individuals who were sort of falling through the cracks, who might not have had those options available. And then we launched, as I said, the COVID PAP. So I think awareness it becomes just as important as just the availability of particular programs. And it would be nice, at least from my perspective, it would be nice if there was an ability for a clearinghouse, something like getinsulin.org across the board, that allows people to know what's really available. And Joy, I think I think actually, in terms of your role as a CDCES, about how you sort of scrap for putting things together. I remember as a regional director for the ADA, early 90s. So again, I've aged myself here too. I had a Rolodex, and
Yay!
yeah, and I was a one-person shop in Norfolk, Virginia, managing 4 volunteer chapters. And guess what? I would get phone calls about. Hey, do you have any insulin in your office?
In your office?
Yeah, and it was just me. Or I need free strips. These strips, and let's, that's another whole concept.
That's a whole nother show.
Yeah, yes, sir.
A whole nother show.
And yet I had created a cheat sheet of places to help people steer them towards. And I wish it would be. I think for providers and other organizations who can, we are putting 20%. We've dedicated 20% of our social media content to be around affordability and making people aware of NovoCare. We have the ability to actually see out in Twitter, because there are people raising their hands up in Twitter. We all have seen it, raising their hands saying, I can't afford my insulin. Well, we are actually actively looking for those individuals and putting ourselves in that situation. Say, if you need help and you're on a Novo Nordisk insulin, come check out what we have at NovoCare and see what's possible. So,
why don't we pull up NovoCare so that we can see how easy it is?
Excuse me. Yeah. So, again, this is just for awareness for people, about, people are concerned about availability and, it's complex and things of that sort. But to be able to understand what the offers are that are available to an individual, it's actually relatively easy from our platform. And again, I'm not going to speak for the other pharma companies, but I'm sure they have other ways of doing it. So if we can, let's show if there's a screenshot. I think there's some screenshots here. So yeah, so this is the front page of the site. You'll see here too. We have as a middle bar within the website. This isn't the full thing, but this is in the middle section. We have a reference to insulin costs. So you'll see we've got a banner, a link there. If you go to the next image there, you'll see, look, we just come up and say, hey, who are you? And you click, who you are, and then you go to the next slide. And then it's a triage mechanism. And again, this gets you information. This does not, I want to clarify this. This is not qualifying information. So there's a whole other process in which you have to qualify. So this is not to say you fill these things out and boom, it's done. It's not. But we do ask some questions. What disease state? Because we have more than just diabetes on here. What medicine, which one of our medicines are you using? What kind of insurance? And then you click and it says get started. And here you'll see some things here. This is part of it. And you'll also see a menu of options where it's sort of like, I need help now. So that's where My99 comes in. That's where references to other insulins, the branded biologics that I talked about, and other programs. And I also want to remind people that, in April of last year, we initiated our patient assistance program for those who were facing job loss, termination of healthcare benefits, and even COBRA extension. I mean, my God, imagine you're dealing with a job that's tenuous, and then all of a sudden you're being asked, oh, hey, by the way, you want to go into COBRA? So we were very deliberate about making sure that we could provide that offering. So that's a bit of showing what's happens at novocare.com. You can go to novocare.com now or after this broadcast and play around with it and just get a better understanding of it. But again, that is one piece of all of this. And like I said, partnerships are going to help people find the solution that's going to be right for them. We have a set of solutions based on our conversations with the community. But we also know there are a lot of other offerings out there too.
Troy, I would just like to state that the ADA, who have played a very active role in fighting and advocating for affordable insulin over the last couple of years. They have a website, insulinhelp.org, in which you can get contact information with all of the companies that sell insulin as well, if you're not on a Novo Nordisk product or whatever. But that website is great. The ADA also has been fighting on the state level, trying to get states to change law, enact laws that will kind of cap insulin costs. And so, all of them are different. We've been fighting in Florida for like 2 years, and we're not moving. But the ADA is committed to
Keep up the
fighting
fight.
for
Yeah.
insulin affordability for everyone.
Yeah, I'm really excited to to dig in. I've never used getinsulin.org before, but just thinking about the ways that we process, help for people throughout the day, I feel like, shout out to Beyond Type 1. We may need to bring you on the show to share. But I think it's really, really important to organize all of the possibilities in the action plan for people, not only for the people living with diabetes, but also for their care teams. We all work together to make this happen, and we're limiting how much more work we can achieve by having to kind of piecemeal everything. And I think, go ahead.
Sorry, go ahead. No, I've got one other option, one other thing I wanted to bring up.
Oh, okay.
You finished
and I
your
think,
thought.
no, I was just finishing up by saying, and I think that it's one of the reasons I appreciate Cities Changing Diabetes and ADA and all of the things that I volunteer with, is because we take this foundation of wanting to help and make people's lives better and help people thrive. And we bring to the table all of our own assets and our own individual assets and our who we work for assets, and we put them on the table together, and then we come up with something that works for people.
Absolutely.
Yep.
We had an earlier part of our conversation earlier spoke about the underinsured, and because we've been talking about people who are really don't really lack resources, but there's still a population out there of individuals who wind up with a high deductible health plan, and they have good medical coverage, but you're dealing with the first 3 or so months in which you're dealing with that, and it becomes a question of what's available for them, what options what can be done to help those individuals, and beyond the offerings that people can consider and see if they're eligible for. Is something else that's really important. That is, there is a policy solution to people to help people afford insulin with high deductible health plans. So in 2019, in July of 2019, the IRS designated insulin as a preventive medicine. And that's important. So now all of a sudden we're bringing the tax man into this, but that's important because there's a whole classification that the IRS designates for insurance companies to understand how to navigate their own tax requirements. What's considered a preventive medicine? There had been the language was vague up until that point. So you would find probably half of the insurance companies in the U.S. consider insulin a preventive medicine, which would mean if you're in a high deductible health plan, insulin gets what's called first dollar coverage. In other words, you don't have to pay list price. You wind up immediately paying copay, along with a whole lot of other medicines that would be considered preventive. But that's only 50%. So what happened was in 2019, the IRS said, no, we're going to officially designate insulin as preventive medicine. So there are a whole bunch of insurance companies that are out there that could, if they offer a high deductible health plan, they could actually opt in and say, okay, yes, we will include insulin as part of that preventive medicines list. So it wasn't an immediate fix, as in it turned the switch on, and insulin became, got first dollar coverage. People have to ask for that. So if you're in a plan, or if your employer offers a plan, talk to your employer and have them talk to the insurance company about seeing about asking the insurance company to register insulin or designate insulin as a preventive medicine, because then that changes things dramatically for those people with high deductibles. So there's still a lot of
awareness.
Absolutely, and there's still a lot of work to be done on that too, on that front. So yeah, just another important tip. I think in many instances when not only did I hear also, because as a spokesperson for my company, you can imagine a few years ago, up until for a while, I was fielding a lot of calls, media calls and the like around insulin affordability, and it is challenging to know that that we have a system that isn't working for everybody. And part of our commitment is really around working with everybody. That's why I said at the start, we talk to a lot of folks. We're always negotiating every day to find ways to make sure that our medicines are getting on formulary for people in those who have commercial insurance, and also ensuring that if people need help, they know how to call us or get hold of us at novocare.com. So again, and I'm saying thanks for this conversation. I also want to say thanks because I'm very passionate about this, because again, I think about my time in that chair in Norfolk, Virginia, and still hearing the same things over and over again.
Yeah, for sure. So I would like for each of you, this has been a really great conversation. I'd like for each of you to sort of just give me some of your opinions on, or an opinion on what you want to see in the coming years, regarding access to these life-saving medications, especially insulin, and in a way that's specifically related to the challenges around health equity and health justice for our most vulnerable communities. What would you like to see happen?
Well, I'll go first, and I'll just lay it on the line. I think that we need to have some form of universal insurance coverage for everyone. If we're going to expand Medicare, we need to expand Medicare. Diabetes is such a progressive disease, and it goes unmanaged for so many years. I mean, you cannot catch up. And so we have a large percentage of people who are just out there, and they're just trying to make ends meet. They work every day, and they deserve to have access to quality health care, not just affordable medications, but a quality health care. And I think that we talk about how this is a partnership, and I would like to see, our federal government somehow, work out a way where we can make sure that people. It's nice to have the programs that the drug companies provide, but we need sustainability, and I think that's going to be the only way that we get there. It has to be some type of effort to improve the access to affordable health care, period, in general. So I think that will answer all of those questions.
I'm not going to make policy predictions or requests as Otis did, but I think there are a couple things that I think we're very keen to see happen. One is we want, you talk about sustainability. I think one thing to rest assured people here who are watching, listening to this, the program, there's been a lot of talk about, COVID, what happens after COVID. Those programs I just talked about, they were there before the pandemic, they're there after the pandemic. And, we're going to continue to keep those programs going because we know they are getting used, and people do tell us, I know there's a lot of skepticism about, well, you have that's a bunch of people. I literally seen this. It's PR. It's all about PR. Really? I actually had someone on Twitter say, give it to us on Twitter. And then when we said, you can get this, and then they tried it, literally 2 seconds later, they're like, oh, thank you. These things work. So I think, again, it's about us being very close to the community as we're talking right now. as we talk in cities and cities changing diabetes and in our conversations, understanding that where those needs are, and doing, and working with people like our PBM business partners, like employers, and making sure that they're aware of that the decisions that are being made around how those healthcare dollars are being spent, it's having an impact on people, and we can't do it alone. I think we talked a lot about partnership. But we're always actively talking to people about the healthcare system that we have right now. That's the one that we're gonna really work with and work it really hard to make sure that our programs are available to people, but also making sure that the access is going to be there for people as well.
Oh. And for me to connect what both of you are saying, I think policy, programming, and then coming back to our community connections. I think, as we progress towards a day when we can say, access for all, we can actually definitively say access is for all. I think as we move towards that, it's going to take community partnerships, and it's going to take grassroots, organizations that live where people live and listen to what people say, and people like our peer support lead, Serena, who works with people and listens to this every day. I think that getting the information to them, getting the access to them, having them drive the awareness is where we'll head towards something that's better for everybody. So thank you both for being here so much.
Thank you. This is great.
Really a pleasure. Really enjoyed the discussion.
Yes, and I want us to do it again sometime in some way.
Thank you.
For sure.
And eventually maybe in person. So
in person.
How about that?
With all of our instruments.
Right.
We're going to take this on the road.
Yeah, take it on the road. Thank you all so much.
Thank you.
Stay safe, everybody.
Bye.
Bye-bye.
So medication access is a challenge that too many people face. It's a burden that impacts the foundation of patient-centered diabetes care. And so I just want to thank Ken and Otis again for everything that you're doing to bring awareness, improve access, and to provide the navigation to people living with diabetes so that they can use patient assistance and patient support programs. We do have a quick survey on YouTube and Facebook where we would like all of our viewers to send your feedback about the program and maybe even ideas for future sessions. Please make MyDiabetes HQ Live better by filling out this survey for us. Mark your calendars. Our next episode will air on May 1st, 10 a.m. Central, 11 a.m. Eastern. We hope to see you there. And thank you so much for being a part of the MyDiabetes HQ family. See you next time.